Hello, everyone. Have another PowerPoint lecture for you today, and today this one's on dual diagnosis. And co-occurring substance abuse disorders, which are those that have comorbidities with mental, emotional diagnoses of other types, have proven to be very common in the treatment field. We run across clients all the time who suffer with co-occurring disorders. And you may hear them referred to as co-occurring disorders, comorbidities, dual diagnoses, but when you're hearing that, and it's all referring to the same thing. And so don't be confused by that. Once upon a time, Bill Wilson and the first 100 or so members of Alcoholics Anonymous got together and wrote something called the Big Book. And in the Big Book, they said that at one point in there that we found that when we weren't drinking, that when we weren't under the influence of alcohol, we reacted much as normal men. And it was their contention at the time that there wasn't any more mental illness among the alcoholics than there were in the general population. What we know today is that's simply not true. In fact, over 50% of the people that we work with will be diagnosable with something other than just their dependency. And there's a strong likelihood that that's something that they will be diagnosed with is bipolar disease, which is probably the most represented illness among the comorbidities. But we also have high numbers of people who are suffering from anxiety disorders, who are suffering from PTSDs, because the lifestyle that drug users live sometimes can be traumatizing, and we'll talk about that today too. I'm not trying to make psychiatrist or psychologist out of you, and I'm not qualified to do that. I'm an LCDC. I'm not a MD or what have you. But if you're going to be working with a substance-using population, you have to be familiar with the types of illnesses that these people bring into treatment with them. And primarily because the symptomologies of these comorbidities get in the way of treatment. And treatment compliance for people who have a mental disorder or a mental diagnosis, if you will, is a huge factor in how well they do in treatment for substance abuse disorders and how well they do in treatment for their mental disorders as well. And they don't want to take their meds, and they don't want to do what's necessary, and it's not their fault that they don't want to do that. That's something I want to underline here before we go much further. So without further ado, I'm going to share my screen with you, and we'll start looking at this. Again, addiction counselors encounter clients with co-occurring disorders as a rule, not as an exception. The majority of the people that are in treatment are diagnosable with some other type of disorder as well as their addiction. A wise old wino told me some years ago that when you sober an alcoholic up, pay attention and see what other kind of problems emerge with that sobering up. Because if you scratch an alcoholic, you find people who have eating disorders, gambling issues, sex addictions, codependencies, etc., and so forth. It's not a simple matter of just, I'm not drinking, so I'm great now. This is tip 42, and a tip is a treatment improvement protocol. And this has been updated this year, so this is kind of hot off of the press. Although a bunch of the information in it has been around a long time, from an initiative to put together a manual, if you will, a textbook or information brochure, whatever you want to call it, to inform addiction professionals who are going to be working with people with co-occurring disorders. And that, by the way, dear hearts, is every one of us will have a client who has co-occurring disorders. And just between me, some of us who are doing the working with them have these same types of disorders too. So, and I'm not pointing fingers or being flippant, they're serious things. If you want to look to really understand, what the point of all this is, review tip 42, chapters 1, 2, and 3. And a lot of the information that are featured in these slides are from tip 42, and some are from other places as well. And I'll credit those places I get to them if my memory holds. Mental illness is highly comorbid in people with addiction and is associated with low rates of treatment engagement, retention, and completion. Sometimes the symptomologies of these illnesses for people who have thought disorders, for instance, who have schizoaffective disorders or who suffer from the anxiety or personality disorders, the symptomologies of their illness looks like resistance to us. It looks like manipulation to us. And consequently, to use a scientific term, we cop an attitude, and respond to them as if they're bad actors instead of sick people. And if we're doing that, then we're doing them a disservice, and we're doing our profession a disservice. We're also doing ourselves a disservice, but that should be third in the line too. Because of the likelihood of encountering comorbidity, co-occurring psychiatric substance abuse disorder, or dual diagnosis, as I said, they all mean the same thing, it's important for a licensed chemical dependency counselor to be prepared to work with the reality that our clients are often dual diagnosed and their symptomologies are going to get in the way. Services offered to dual diagnosis clients on our part are limited by our scopes of practice. I can work with anyone with any diagnosis as long as I stay within that narrow focus of helping them out with substance use disorders and working within the area of substance use disorder. If I'm on a treatment team and I'm working with therapists and doctors and whatever, I can pretty much supply other services too, as long as I'm directly under their supervision. But I don't want to branch out and call myself a specialist in working with co-occurring disorders, or say that, that I can treat bipolarity or whatever, because I can't. And a whole bunch of these diagnoses, these comorbidities, are managed pharmaceutically. I can't prescribe, and so consequently, it's kind of out of my realm. But I can work in those areas, providing counseling and education and information in the areas of substance use disorder. Whenever and wherever possible, we should not exclude people who from participating. And like I said, they can be frustrating because of the symptomologies of their secondary diagnosis, or maybe it's their primary diagnosis. But because of the symptomologies that are associated with bipolarity or with thought disorders or something like that, it's going to increase the risk for their relapse. It's going to decrease their ability to follow up with treatment recommendations, or to stay on a regimen of medication or whatever. Management of mental emotional diagnosis symptoms are critical for successful substance use disorder outcomes, and if we can't get them to follow through on that, we're going to have a lot of relapses. Just between you and me, as long as they keep coming back, I keep working with them. And I know that they're going to have these problems, and that these problems are not of their own making. If it was a matter of just not liking the symptoms and saying I'm not going to choose to have those, I mean, who would? Who would? They're very disruptive to one's life. They're very disruptive to one's ability to function with other people and achieve levels of happiness and all of that kind of good stuff. So managing the symptomologies is difficult under the best of circumstances. Consequently, when clients are coming in, screening and assessment of clients is critical in determining what kind of services they need, when they get them, how they get them, who's going to deliver them, in what circumstances and situations will they be delivered, etc. Down here is is a link for diagnosis and scope of practicing, etc. Scope of practice, etc. Our scope of practice is a document that limits the types of services that we can provide, and who we can provide them to, and how we can provide them, and when we can provide them, etc. And you should get familiar with that, by the way, because it does dictate what constitutes ethical and legal practice in the state of Texas. Addiction counselors in our state, and pretty much all across the United States, do not make mental diagnosis. Now, I may see someone who's exhibiting every symptomology of schizophrenia that there is under the sun, and say, well, and I've worked with so many schizophrenics that I feel quite competent in doing this. I am not legally competent in doing this. What I have done in the past, of course, and what we can do is make diagnostic impressions, so that when we're doing screenings and I'm pushing this up the line to my medical director or what have you, I might say rule out schizophrenia because of da-da-da-da-da. And these are the symptomologies that I have seen this client exhibit, and this is what I think about it. And then I just push it on down to the next person who will either agree with me or disagree with me and formulate a different diagnosis. So in a sense, this is also freeing for us, because diagnosis is a pretty heavy responsibility to have. We should become familiar with the diagnostic criteria for mental illnesses that commonly occur with substance use disorders. If nothing else, so that we'll be able to refer clients for, further psychiatric evaluation, and to tailor treatment services accordingly for those that we know do have these illnesses. And I'll incorporate, for instance, following up on their regimen of medication, making sure that they're getting their prescriptions filled and that they're taking it when they're supposed to, as much as I can. Also knowing that I can't force anyone to do this, and that's out of the realm of possibility, and that I can't, prescribe. So, some common CODs that we see, some common co-occurring disorders, are major depressive episode and persistent depressive episodes, or dysthymia. Bipolar 1 and bipolar 2, there's two of them, and bipolar 1 is the more serious and more problematic in our line of work, although bipolar 2 is also an issue, and the symptomologies of bipolar 2 are less than the symptomologies of bipolar 1, but they're still significant. And post-traumatic stress disorder. And PTSD, by the way, probably should fit in and does fit in under the generalized, under the anxiety disorders. And we'll talk about that a little bit later on. But post-traumatic stress disorder is a response to something that happened to you. And and I'll talk about that in detail when we get to it, but it's a lifestyle or experiential type disorder. Borderline and antisocial personality disorders, we'll talk about those too. These are things that occur to a person as well. We don't always know what brings them about. Some of them, like borderline, is believed to be rooted in bonding with your parents in early childhood, particularly with your mother, and not successfully, by the way. Then we have schizophrenia and other psychotic disorders, and these are organic in nature. We don't know, like some of the mood disorders are. We don't necessarily know what causes these types of things to happen to people, and we haven't been real good at curing them, but we are getting pretty darn good at managing the symptoms to where people can live relatively happy, fulfilled lives, in spite of their conditions. Then we have the anxiety disorders, the generalized anxiety disorder, panic disorder, social anxiety disorder, a bunch of other things, OCDs, obsessive compulsive disorders, etc. Attention deficit hyperactivity disorder, I'm going to talk about that a little bit and the implications for that and treatment, particularly with kids, but also we see it in adults too. And it can frustrate counselors as well. There's a whole bunch of behaviors that people who have comorbidities can display for us that will bug us, that will make us angry and will frustrate us, etc. So, forewarned is forearmed, right? Then we have the eating disorders, anorexia nervosa, bulimia nervosa, binge eating disorder, and some others. Depressive disorders. Depression sometimes is referred to as the common cold of mental illnesses. The thing that there are a couple of kinds of depressions that you can have. Everyone gets depressed. Depression is something that happens to everyone at some point in their lives. It happens to people early on. If it's raining outside and I can't go outside and swing on my swing, and I'm 3 years old, I'm depressed. It's not going to scar me for life, probably, but I'm depressed because I didn't get what I wanted to do. My depression is directly linked into something in my environment. It's raining, I can't swing, therefore I'm depressed. That's called an exogenous depression. And an exogenous depression is one that's outside me in terms of causes. If I get ready to run to the store and back over my favorite kitty cat, I know why I'm depressed. And I know what that depression's about. And that depression can be around for a long time. And that depression can reoccur every time I think about the cause of it, for that matter. So it's something that might fit up here in this direction of the lost. But then I get the very lost too. And that's the depression that hits me and knocks me down, and I can't get up, and I can't do anything, and I can't concentrate, and I can't sleep, and I can't eat, or all I can do is eat, and all I can do is sleep. My life is terrifically disrupted by this, and people can point out to me, well, look, dude, you've got a nice job, you make good money, you're You've got a nice wife, she's pretty, she's sweet, yada, yada, yada. You should be grateful, you shouldn't be depressed. And I know they're telling me the truth, and I kind of casually hate them for it, because even though I know that all of that's true, I still feel like jumping off a bridge. There's nothing I can point to outside myself to make me feel this way. That's an endogenous depression. That's something that's in me, and it's probably chemical. We treat it with pharmaceuticals to manage the symptomologies of it, as a matter of fact. So symptoms that cause clinically significant distress or impairment in my mental well-being, my social abilities, my occupational or other important areas of functioning, are part of this depression. If I have a type of depression like this, it's not attributable to the physiological effects of a substance or some other medical condition too. People who are diagnosed with serious illness are often depressed for very prolonged periods of time because of the frightening and difficult nature of the illness, their difficulty in accepting it, and the complications of managing the treatment, etc., and so forth. And as a friend of mine said one time about depression and substance abuse, if you spend 15 years of your life every day pouring a quart of depressant into your body and you stop doing it and you're depressed, go figure. Anyway, the occurrence of major depressive episode exists if it's not better explained by schizoaffective disorder, schizophrenia, delusional disorder. And those are all thought disorders, by the way, but there are thought disorders that have a mood feature to them, and the depression is the mood feature. We'll talk about that a little later on. And if there is not associated with this depression that you're having, there's not a manic episode or a hypomanic episode. Depression is common as dirt with substance use disordered population. A good part of the time, if the longer a person stays sober, you'll see that depression seems that the mood elevates on its own, that the further they get away from their drug using episodes, that there's a lessening of symptomologies and an increase of mood. What that would indicate is that the depression was related to the substance use. But there are also people who sober up, and it doesn't matter much how far they get away from their last substance use episode, they're still depressed. And this is, and maybe they've even been using the substance to treat the negative symptoms of that depression, of self-medicating, which happens with the substance use population anyway. We talked in another class about secondary or reactive alcoholism, for instance, one that grows out of a traumatic event. People start drinking to cope with that traumatic event, or it comes out of another type of disorder and people are medicating the disorder. Even if we do an intervention and we get the people who are self-medicating and we identify a better method of treatment for them, give them other things to manage their symptoms with, treat their depression or whatever the comorbidity is, they may still have a substance use disorder to deal with because they've drunk and drugged themselves into one. Treating one thing does not necessarily make the other thing go away, so that both illnesses basically have to be treated. Persistent depressive disorder, dysthymia, has a low mood that simply will not go away, and it persists, hence persistent, It persists over time, and it persists through circumstances, etc. And though it may get better and it may get worse, and the pendulum kind of swings, it ebbs and flows, it's pretty much always there, it's pretty consistently there. And when you have this is something that you take Elavil for, or some other type of mood elevator. You may take antidepressants, SSRIs, SSRNs, and SNRIs, I mean. Anyway, it can be debilitating. The symptoms do cause clinically significant distress or impairment, and it gets in the way of social and occupational functioning and other important areas of functioning. And because it does that, it can sometimes be confused with other types of disorders that are also fairly common. So it takes a pretty good bit of skill to kind of suss these things out, what's what and what's causing which. Bipolar disorder. People confuse this all the time. They say things like split personality. There's no such thing as a split personality. Bipolar disorder is swinging between extremes of mood, and both extremes of mood are debilitating. We'll talk about that later on. But anyway, bipolar disorder may be the most representative of the comorbidities that are associated with SUDs, and around 60% of comorbidities that are found are bipolarities or bipolar disorders, either bipolar 1 or which is more common, or bipolar 2. Bipolar 2 honestly may be more common and just not as diagnosed as prevalently. If you have bipolar disorder, you're going to have a poorer prognosis. That means that your positive outcomes in treatment are lessened significantly, not because you don't want sobriety, or not because you're not committed, or not because you lack motivation, but because you have comorbidity, and this comorbidity is not being managed in such a way that you can be successful in SUD treatment. And over time, over the years, in my experience anyway, it's one of the things you get to say when you get old, right? In my experience over the years, I have seen people wash out of programs and be blamed for washing out of programs for things that really aren't their fault. It's not their fault that they have these symptoms. Other comorbidities, and by the way, people with BDs tend to wipe out of substance use treatment, but they also have substance use disorders that wipe them out of their treatment for bipolar disorder, their mental health managements. So these two illnesses inform one another and make each other worse as you go through the process. Other comorbidities that you may see with bipolar disorder include obsessive compulsive disorders, OCDs, eating, cardiovascular, sleep apnea, and these comorbidities are also common in substance use disorders with no bipolar diagnosis. So that too can be confusing in how to pull that out and manage that diagnostically. Of the two bipolar disorders, bipolar 1 is the most serious form of the illness. It has more virulent symptoms. This is a swing back and forth between moods. And if you have mania, is kind of like a hyperactivity that's going on. People talk fast. They are hyper confident in themselves. They may be arrogant, and active, and doing risky things, doing all kinds of things that, are ill-advised, like cleaning out your bank account and investing it in a worm farm, that kind of thing. Engaging in risky, sexually adventurous behavior because you're the world's greatest lover and dancer and smartest person on earth too. So all of this stuff is part of the manic symptom. And this manic symptom is the key to recognizing bipolar disorder from unipolar depression, the persistent dysthymia, or I always mispronounce that, dysthymia, the persistent dysthymia, or the unipolar major depression single episode. Those don't have a manic component. And there are interventions that you use with bipolarity that do not work. And this is medicine, pharmaceuticals that don't do much for unipolar depression and vice versa. So that the medications you take for unipolarity don't do much with treating bipolarity. Bipolar 2's feature is hypomania rather than hypermania. It doesn't get as pronounced. The depression looks pretty similar. The depression's pretty heavy, but the hypomania is still mania, but it's low-grade mania versus high-grade mania, hypermania, that you see with bipolar 1. Most of these disorders may be treated with medication combined with counseling, and that's not particularly uncommon. But of the interventions, the preferred method of treating them is medication. And there are good, effective medications that manage bipolarity symptoms. But the client sometimes, and again, this is part of the disease, don't want to take their meds. They have certain beliefs about them. And the side effects of a lot of the medications, particularly those that treat psychosis, for instance, like chlorpromazine, Thorazine, have some real nasty side effects with them. They don't feel good. Haloperidol has nasty side effects. It doesn't feel good. So people don't want to take it. People also don't want to take their medication because they don't want to feel different than other people. They don't want to feel like they're dependent on these medications, which is sad because they are dependent on these medications. And that's the bad news for people who are taking psychotropics a lot of time to manage mood and thought disorders, is that they would like to envision a point in the future where they don't need their meds, and there really is no point in the future where they're not dependent on their meds in most cases. Trauma is found across the spectrum of substance use disorders and mental disorders as well, and trauma-informed techniques should be used with these clients to understand where they're coming from and why they're behaving the way they behave, and detailing or directing their treatment efforts appropriately in the face of this knowledge. Nearly all co-occurring disorders carry an increased risk for suicide, and you're going to have to, if you're working particularly with depression, you have to be constantly aware and constantly assessing your clients for risks of self-harm, because they're the population that's most likely to do it. And a substance use population is more prone than the population in general to take steps like suicidal gestures. Even among people who are not substance use disordered, people who aren't co-occurring, people who may have experienced some, terrible thing in their life, and they've decided they're going to end it all, they're going to jump off the Hartman Bridge or whatever. They'll have a few drinks before they do it. So there's a real tie-in with substances and suicidality. There's an even greater tie-in where you have substance use disorders, comorbidities, and suicidalities. Let me go back here for a minute before I go to that. People who are depressed, I remember back in the late 80s, early 90s, when there were these new non-specific drugs out that were good antidepressant drugs, but they were accused of, there were accusations that they called suicidality among the patients who took them. And these non-specific antidepressants that we later found out were selective serotonin reuptake inhibitors, or SSRIs. Key among them was Prozac. So that if you give a depressed patient Prozac, then that depressed patient is going to have an increase in suicidal ideation and probably a higher risk of suicidal gestures or completing suicidality. And this was all because they took Prozac, right? I dispute that, as do a lot of other studies. There may be an increase of suicidality to some degree with some patients, but it's not that widespread. Of all the people with all the mental illnesses and with all the other illnesses in the world, who do you think is the most likely to want to kill themselves? What? Exactly. The depressed people, the people who have depression, and it can be bipolar depression because there's a high incidence of suicide attempts among bipolar people. It can be unipolar depression because there's a very high number of attempts by depressed people to unipolar depressed people to kill themselves. And that's because, newsflash, depressed people want to die sometimes, and they're more likely to try to die than people who are not depressed. That's another, for me anyway, is another moment of awareness. But nearly all co-occurring people have increased risk for suicide, particularly if that co-occurring disorder is some type of depression. People who get really drunk and start feeling sorry for themselves are also at risk, even if they don't have a history of depression. They may do something impulsive that they shouldn't do. I'm thinking of Jeff Alm. He was an offensive lineman, played for the Houston Oilers. Remember those guys? He was a ferocious, big, young bull of a guy who was totally gay and was riding with a friend one day, and they were intoxicated. And I don't know this for a fact, but rumor was they were engaged in some sort of thing they shouldn't be engaged in while driving down the highway. But that's neither here nor there. Point is, Jeff Alm had a car wreck, and he threw his friend out of his car, and they were on an overpass, and it threw him over the rail and down into the road of the freeway below, where, if the fall didn't kill him, getting hit by 2 or 3 cars did. Alm was inconsolable, and he called 911, and he was hysterical. Oh my God, I've killed him, do something, help me, oh my God, boom, and he shot himself on the side of the road. And that was not planned. That was not something that you could assess for, but that's something that happens with people sometimes during certain circumstances. Still a hell of a tragedy. Post-traumatic stress disorder, PTSD, which basically, I don't know if it's post-traumatic because it was an ongoing stress event when Alm killed himself, but PTSDs are exaggerated fear responses that occur following exposure to one or more extremely upsetting events. And sometimes, I think in our society, in our country, at our time, and in the space we inhabit right now, the tendency is, when we think of a PTSD, is to think of someone who fought a war, a Vietnam guy who came back and, was totally messed up and doing drugs and having nightmares and all that kind of good stuff. That is a type of PTSD, but I've had PTSD from people too who I took a trauma resolution therapy training way long time ago, back in the 90s, and the guy told us, he said, this training is going to consist of trauma with a big T. It's not little t trauma like you didn't get your pony on your 7th birthday, or people made fun of the way you dressed because you had to wear hand-me-downs and all your older siblings were girls. But big T trauma, parents of murdered children, big T trauma. And so experiencing something, one of the cases we studied was a woman and her fiance were coming back to their apartment after a date. They'd been somewhere doing something, and they were assaulted in the parking area, and I think it was a garage. But anyway, her husband, her to-be, was murdered, and he was beaten to death with a club, and she was raped in a puddle of his blood. Big T trauma. And so what she was doing was trying to get beyond that, because, as you might expect, that interfered in her relationships, her ability to sleep, her ability to park her car, all kinds of things. Equally as much, and we don't think about it sometimes, is how often does a substance user, for instance, do something like sleep with a stranger in order to get money to acquire drugs, and sometimes, put themselves in positions where they're raped or beaten up or mugged or ripped off, shot at. How many times have you got to be in an overdose situation and to have these types of occurrences have become post-traumatic stress disorders. There are 4 categories of symptoms that are associated with that. And people who have it tend to have intrusive, persistence, re-experiencing of the trauma, nightmares, flashbacks. Lady I know was sexually abused as a child, and for whatever reason she associated dead animals with it, and then sometimes just small animals in general. If she saw a piece of rubber flung off a tire lying on the side of the road, she would turn around and drive 20 miles to get around it, because it might be something dead, might be roadkill, and she couldn't get past that. Consequently, you see things like persistent avoidance of people, places, things, etc. Anything that reminds of the event or that triggers these memories. In the case of combat vets and things like that, negative alterations in cognitions and mood, memory loss. It should be guilt instead of guilt. Guilt, particularly survivor's guilt, comes into play. Depression, inability to sleep, fear responses, marked alterations in arousal and reactivity. And that one is a little tricky too. I saw a guy with PTSD, and I made that diagnosis from half a world away without even being qualified to do it. And I know he was suffering from PTSD because he was in Rwanda at the time of the civil war there, when the Hutus and the Tutsis were mixing it up. And the circumstances was, here was this tall black guy. He's wearing tan pants and a Hawaiian shirt and sandals. He's forever in my memory, as clear as anything. And he's carrying groceries, and he's walking down a street in this Rwandan city, and militia are killing each other all over the place. There's explosions you can hear in the background. There's gunshots going on. There's bodies in the street. There's bullets whizzing around. And he's walking right through it all, carrying his groceries like he's out on a walk in the park. He has absolutely no fear response, no horror at the dead lying around him in the streets. He's just going home with his groceries. That is PTSD, and that's a marked alteration in arousal and reactivity, where you're not taking any steps to ensure your own safety, for instance. This is common with substance use disorder. Because of the lifestyles associated with substance use disorder. We do dangerous things and put ourselves in dangerous situations. Treatment issues are that symptoms interfere with substance use disorder recovery, and substance use disorder recovery interferes with recovery from PTSD. PTSD may be managed with medication and counseling. And people will take anxiolytics, mood elevators, some other type of substances prescribed to them by a doctor. And if they're being treated for trauma, with trauma-informed approaches, then their counselors, their substance abuse counselors, are aware of what those issues are, and they're cognizant of it, and they bring the treatment plan up to date with trauma resolution outcomes in mind for people who have that. Then you have personality disorders. And personality disorders are, well, basically they're forever. I know of no way that people have ever really cured a personality disorder, although they are managed often and relatively successfully, to an extent that people can be pretty happy with their lives, even if they have a personality disorder. Faking it till you make it sometimes. A person's lifelong inability to form a healthy, functional relationship with others, and a failure to develop an adaptive sense of self, of social competence. And adaptive means healthy and effective. Is something that we have circumstances arise in our lives, and we come up with a good problem-solving skill to address them, and we do that, and we get better, and we have a sense of self, of social competence through that. Personality disorders are a way of being that deviates from cultural expectations and norms. We do things that are socially awkward, for instance. And there are a lot of socially awkward people who say the wrong thing, who talk too much, who are saying things when they should be quiet, who who remain quiet when they should be saying something, who, you name it. That's, you give me a social situation and expect me to behave one way, and I expect another because I don't know how to behave otherwise. But there's also other personality disorders, and we'll talk about those too, where I don't really understand why you want me to behave this way, but I understand that you do want me to behave this way. There is no intrinsic payoff for me other than the fact that I can hide my awkwardness and my deviance from you by behaving the way that I think that you want me to behave. And some people are real good at that. We call them sociopaths most of the time. And personality disorders are a way of interacting with the world that causes stress or problems in functioning, that things don't work out for me. And personality disorders are probably the most stigmatized of all the comorbidities because people don't understand them. And they don't understand that people are not necessarily in control of their personality disorders. In most cases, if something's wrong, if you have an illness, you want to get it fixed. But a personality disorder may be, this is just me, and you won't deal with me. You won't accept me because this is me, so I have to find a way to deal with you. And the way that I deal with you primarily is as a chameleon. And I'll pretend to be what you want me to be so that you'll either accept me, which is kind of a lofty goal. I really don't care if you accept me. I want you to leave me the hell alone. Does that make sense? Okay. Types of PDs. Borderline personality disorder, that was defined by Dr. Freud. Sociopathic personality disorders and dependent personality disorders. There are others too. I think they've got them subdivided down to around 10 types now. But for the purpose of this conversation, the borderline, sociopathic, and dependent types of personality disorders are the ones that we'll look at. The borderline is characterized by a history of unstable relationships. It's believed to be rooted in childhood bonding or lack of. There's lots of things that the borderline brings forward into adulthood that's problematic for him or her. It's generally a her who is diagnosed with this. It's difficult to accurately diagnose because some of the symptomologies look like they could be other things. The symptoms most definitely interfere with substance use disorder treatment. And in fact, substance abuse is a diagnostic criteria for making a diagnosis of borderline personality. They tend to drink too much and to abuse drugs or abuse drugs. It doesn't have to be both. It could be one or the other as well, or both. Substance use disorders are people who, disordered people, you can see she's got her little mask there, and they're almost like the dramatis personae, the drama mask that we looked at with the bipolarity. The tragedy on one side, comedy on the other. But the real truth is that the borderline personality is generally a pretty consistently miserable person. They're not happy. That probably has a great deal to do with their history of unstable relationships. They are very mercurial in their mood, so that there's not, this personality disorder also has what seems to be a mood feature with it. They're quick to anger, and they don't have any problem with sharing that with people most of the time either. They demand love and refuse to accept it. They demand truth but refuse to accept it. and they set you up with tests. They need to be rescued a lot, and they also, like things like proof that you love me. So, give me what I want without me telling you what it is that I want. And if you really love me, you'd know. If I have to tell you, it doesn't count, that kind of thing. Consequently, they have a history of unstable relationships because it's pretty difficult, if not impossible, to meet those standards. They tend to abandon other people because they're insecure of being abandoned themselves, so that they'll this is by no means a comprehensive description of one person. But these are traits that are part of the borderline personality diagnosis. Whew. Had a student ask me a few years back, what do you do when you encounter a borderline personality like that, Mr. Bushart? And I told her that my first instinct was to propose to her, but I'm getting better. So, sociopathic personality disorder. You may know who that person on the right is. Anthony Michael, no, it's not Anthony Michael Hall, it's Michael something or another. But he played a character, Dexter, on television. Dexter is a serial killer. And he only kills other serial killers, by the way. So if he's got people that are, people that are doing mean things to other people, he does a vigilante thing on them. Not because he's so just, but because this is a way he's learned to manage his impulse to kill. He has no empathy. He feels no remorse for the things that he does. He has no sense of guilt. He sees other people as means to an end, as a way to satisfy himself. And he's very, very manipulative. He is totally self-absorbed. He sees everything in terms of what's good for me. What will I like? What I like, what makes me feel good is the greatest good. What bums me out is the greatest evil. He has no pity, no remorse, no guilt, no conscience, none of that. So consequently, if you meet a sociopathic personality disordered person, they don't mind manipulating you. They don't care if you get hurt in the relationship. They may care if they get caught in a relationship. And I have a feeling some of you out there are nodding your head because you've run across this person before. I know I have. A girl I went to school with back in the day when I was an undergrad was telling me a story about, and this was kind of strange because this was a girl who went to AA meetings even though she wasn't an alcoholic, because she liked it. She liked the camaraderie and the ability to be in there and share with people and what have you. She met a guy there who was a guitar player. That should have been a red flag in itself. But he was pretty much a womanizing relapse artist, and he had his own issues. One of his issues was, from what she told me, was a little bent towards sociopathy. Anyway, being the good woman that she was, she married this guy. And she married this guy and put him on her insurance so she could put him into treatment, right? And get him well. He didn't have insurance, of course. So she married him, she put him into treatment. He got out of treatment, relapsed again pretty nearly immediately, of course. Seems he'd been sleeping with her roommate almost from Jump Street. So he ran off with her roommate in one of her vehicles and left her with about a $10,000 out-of-pocket expense for his treatment. which surprised her. Because even though this dude had all of these sociopathic type tendencies, my girl had some real dependent personality issues too. For instance, thinking, if I do this for him, he'll see what a good person I am. He'll see that I'm a loving person and he'll love me back, which he was probably not capable of doing. Or maybe he was just unwilling to do it. I'm hypothesizing here. But point is, people with sociopathic personality disorders, they don't feel guilty about the things they do, although they may have learned to pretend to feel guilty over time because they're often not as slick as they think they are and wind up getting caught doing things. And they'll find a way to gaslight you and make you think it's your fault, or they'll grudgingly pretend to be guilty about it and do insincere apologies and what have you, so they can do it to you again. And you'll let them if you have a dependent personality disorder. Schizophrenia, the term schizophrenia, schizoaffective, all of those disorders are delusional disorders. They're thought disorders. Schizophrenia literally means shattered mind, and you can see this guy here who's fragmented into puzzle pieces. It's a psychotic disorder. Psychosis is when you're not in touch with reality, or you may be in touch with some reality, but it's not established reality. It's not the reality that the rest of the people in your environment will agree is the reality. It's delusional. Delusional is when delusional is when you believe that QAnon nonsense and think there's some truth to it. Is believing things that aren't true, is seeing things that other people don't see, hearing things that other people don't hear. Your dog's talking to you like the son of Sam. Your thinking's disorganized. Your behavior is clearly abnormal. These types of disorders are fairly obvious when you run across them. Believing that you can't get out of the circle of light at the end of the street where the lamppost is because that's the last oxygen left in the world. That happened at a homeless shelter. Believing that your phone talks to you. Not someone on the phone. Your phone talks to you. That kind of thing. Schizophrenic. These are difficult clients. The symptomology of the illness can be awfully frustrating for the counselors. I had a client one time back in the 80s, late 80s, who came in and he had. I was in Deer Park, and he came in one day with his girlfriend, and this was kind of odd because my guy was, in his 40s maybe, and his girlfriend was in her 70s. But anyway, he comes in with her, she brings him in, and he's been roughed up a little bit, got a few bruises and bumps on him. And it turned out that his backstory for showing up there that day was that he went down to the Wheelhouse, took a pistol down there, and the Wheelhouse is a men's recovery center in Deer Park, and he was going to overthrow the administration down there because he got a message from God that he was supposed to be running the Wheelhouse, not the people who were running the Wheelhouse. They weren't doing it right or whatever. So he came in to run the Wheelhouse the way it was supposed to be run. And the people who run the Wheelhouse weren't really, ready to comply with God's will, so they took his pistol away from him, smacked him around a bit, and sent him out. And being the good, thorough counselor that I was, and having all the experience that I had, which was very little, by the way, I asked him things like, well, how does God talk to you? Did you hear him? Did you hear a voice like I'm talking to you? Or, was it in your head? How did you hear this? How did you know? And he told me that the wires in his stomach coiled real tight. And when they got up to a certain tenseness, a certain tensile, I guess, measure, they'd spring free. And the wire would go up his backbone and fire out the top of his head. And there were leather flags that told him what God wanted him to do. And I really didn't know where to go from there. Don't drink, read the big book, call your sponsor, go to a meeting. Dude was a ex-Navy guy, though. He had VA insurance, and I got him into the VA hospital, and they got him back on his psychotropic medications, his medication management. A few weeks later, he was doing okay. So that worked out. But these types, you cannot counsel people out of being psychotic. You cannot counsel people out of being schizophrenic. Actually, you can't counsel them out of being alcoholic. You can tell them, you can show them some things that they can do to manage their symptomologies and to come to some type of recovery. But when you're talking recovery and mental illness, that's even iffier than recovery and substance abuse. The best that schizophrenics can hope for, as far as I know, and I hope before I die I see that it being different. I see them talking about it in terms of cure. But right now, stabilization and pharmaceutical management is the best that we got going for us. And I can't bring that about with a schizophrenic client. But the minute I notice that there's schizophrenic symptomologies there, I can do referrals. And that's the part that's on me. Neuroses and anxiety disorders. Well, what's the difference? Nothing. They're the same thing. Freud called them neuroses, and people later on began to call them anxiety disorders. That's basically what went down with that. And they're a wide category of co-occurring disorders. They include phobias of all sorts, the obsessive-compulsive disorders, panic disorders, etc., those types of things. And these are things that really get in the way, by the way. A phobia is generally considered an unreasonable fear. Caterpillars, spiders, things like that. The OCDs are neuroses that are fairly common. Y'all ever watched Big Bang Theory? I watched a rerun of that last night, and Sheldon went across the hall to talk to Penny, and he said, "Penny, Penny, Penny," and he had to knock 3 times, and he had to say Penny 3 times. If you interrupt Sheldon before he goes through his little cycle of obsessive-compulsive disorder, he has to come back later and finish it. He cannot walk away from it. If you have an OCD and you're ready to go to bed at night, you may go around the house and check all the windows and doors. And when you get through checking all the windows and doors, you have to do it again. And then you have to do it again. And then you have to do it again. And then you have to do it again. Good luck getting some sleep. These are things that and you can't sleep. You can't leave it alone. That's the key element with an obsessive-compulsive disorder, is that you can't leave it alone. If you get right down to it, all substance abuse disorders look like OCDs. If I'm not using, I'm thinking about using, or how not to use, or how to use successfully next time, or whatever. So that the compulsiveness, the behavior, is totally married to the obsessiveness, the thinking about it. So we'll see a lot of that. Neuroses and anxiety disorders, and again, all of the symptomologies for these are found in the tip 21, which you can, look over for yourself and get the whole list. But you need to be cognizant of these criteria so that you can help the client recognize when this is going on, help them make a referral for further diagnosis and assessment. This is a attention deficit hyperactivity disorder, ADHD, is an interesting diagnosis. This is an interesting category. It's a hotly debated category. There are people on one side who say, well, this is clearly a situation, it's clearly a diagnosable disorder. It's clearly a diagnosable disorder, and it's, and it responds to medication and it responds to treatment. Then you got people on the other side who say there's no such thing as ADHD. It's just kids who, they're unruly. They don't have proper supervision. It could be food dye, or it could be overcrowded classrooms, or whatever.
And as a kid with ADHD, I can definitely say that it is very hard to deal with it, but after a little while, you get used to it. That's all I have to say.
And that's my grandson. ADHD is usually childhood onset and diagnosis. It's almost always diagnosed in males. Sometimes, I don't know. It may be always diagnosed in males. In fact, I've never met a female who claimed to have an ADHD diagnosis. It's not uncommon in adults. And it resembles the symptoms of other disorders. And generally speaking, ADHD is treated pharmaceutically. You give them medication. And the medications, oddly enough, are methamphetamine-like substances, methylphenidate, Ritalin, or Adderall. But ADHD presents treatment issues. And I thoroughly believe, me personally, that it is absolutely a real illness, and that people who are treated for it respond to that treatment most of the time. Then we have eating disorders. Over here, this lovely little wisp of a girl is Dame Leslie Lawson, also known as Twiggy. And she was the haute couture model of the 60s, of the Carnaby Street look. Eating disorders affect mostly women, not entirely women. Let me say this. Anorexia nervosa, bulimia nervosa, they affect mostly women. However, some of the other eating disorders, like overeating, affects men as well. Clearly, it affects men as well. But eating disorders, Twiggy, she didn't weigh 100 pounds. Neither did Karen Carpenter. Karen Carpenter weighed about 80-odd pounds, 85 pounds. She still thought she was fat. She went right home and finished starving herself to death back in the late 70s. She was half of the musical group, the Carpenters, who were very popular at the time, her and her brother, and she's winning some kind of award there. These are control issue disorders. These are people who are, feeling totally out of control in many areas of their lives, who are exerting control over their weight. They have something that they share with alcoholics and drug addicts, which is distorted self-image. These girls look in the mirror and say, well, I can stand to lose a few more pounds here and there, and everybody else looks at him and goes, no, you cannot. An alcoholic who's drinking himself to death will look in the mirror and see a guy who's just having fun and will, who will be able to, control his drinking, just a normal guy having a good time, take it or leave it sort of person. And that's self-delusional, by the way. Anorexia has to do with starvation. Anorexia has to do with food intake, controlling food intake and weight. Generally speaking, anorexia is, they're not eating a lot. They're not eating hardly at all. They starve themselves. They'll use things like laxatives and things like that. Bulimia has a binge and purge cycle to it largely, that bulimic people will eat and sometimes eat a lot and then force themselves to vomit. Again, in an attempt to control intake and have some control in a life that's otherwise for them somewhat uncontrollable. There are eating disorders that involve eating too much, eating all the wrong things. And I think there's, we are, some of our eating disorders are culturally reinforced. Like my grandson a while ago was telling you about his ADHD, also left to himself will eat nothing but burgers, french fries, chips, and candy. If he eats a vegetable, it's only because it was cleverly disguised. And that's reinforced. We're a fast food nation to a large extent. It's easier to go to Popeyes, and I love Popeyes, by the way. And I'm a Southerner, so most of what I like to eat is like, coffin nails, everything that I like. People, we eat for sport. We Americans eat for sport. We eat too much. Our portions are too much. If you go to a restaurant and finish your plate, take it to the bank, you've overeaten. And then you go to places that are temples for the overeaters, places like Kelly's. If you finish a Kelly's breakfast with biscuit and steak, you have eaten too much, dear hearts. Way freaking too much. You probably have eaten too much if you eat a third of what's on your plate at that serving. So it caters to the overeater. The supersized me meals that they used to have at McDonald's were the same type of thing. So people do overeat, or they just eat badly. And fall into a habit of eating badly, and sometimes it's more like an obsessive compulsive disorder where people will only eat the same things all the time. I can't get to this part in the lecture without thinking of Jack Nicholson. I probably ought to put a picture of him in here from that role, but he was in As Good as It Gets, and he had to go to the same restaurant every day for breakfast. He would sit down in the same booth, had to be there. He'd have the same waitress. He'd order the same breakfast. He had his own plastic utensils that he brought with him, so he didn't have to use any of their stuff because he's a bit of a germaphobe. And this is an eating disorder. This is an obsessive compulsive disorder that expresses itself through food consumption and other things too. He's also the guy that when he washed his hands, he had to unwrap a new bar of soap. He used it once and threw it away. You know, it didn't ever use it again. So all kinds of quirky things that human beings can get involved in that create for a substance abuse counselor, that create for us a problematic issue to deal with in formulating a treatment plan and delivering recovery services. Co-occurring psychiatric and substance abuse disorders are very common in the treatment field, and they should be recognized and addressed in treatment. Not necessarily diagnosed by us, but we help people by referring them to places that they need to be, that will meet their needs, that are qualified to diagnose and to come up with a treatment regimen for their co-occurring disorder. Meanwhile, we're going to deliver the treatment services that we do, and we're going to follow up with our clients to make sure that they're complying with their treatment recommendations, if at all possible. And like I said, there are lots of reasons that people don't want to follow up, that don't want to follow directions, because following directions means being reliant on pharmaceuticals, on chemicals, on drugs. We've had issues in the past. It's not as bad as it used to be. Once upon a time, when I first sobered up, for instance, oh no, here goes another Bushart back in the day story. Yep. Well, back in the day, when I sobered up, if you were taking medication, if you were taking Prozac or Paxil, or if you were taking haloperidol or promazine, or if you were taking mood elevators, any of those kind of things, you might have a sponsor who will tell you, hey man, God's everything or he's nothing. You don't need any of that medication. All you need to do is surrender to your higher power and he'll take care of you, man. You can't be sober and take these medicines. You can't be sober and do this, that, and other. And that's been a recipe of disaster for thousands of people who listen to their sponsor instead of their doctor. If you're a sponsor, don't say this kind of stupid stuff. Okay? And don't advise people to not take medication that someone is prescribed for them. You can advise them to discuss their medication with their doctors. That's fair dinkum. And tell them how to go about expressing, their reservations about taking this medication, or expressing how they don't like the medication, they don't like the way it makes them feel. That's all fair, and that's open for discussion. But to tell them not to take it, man, some bad things can come from that, really. So don't do that. In conclusion, co-occurring disorders are common. And the list I presented here are the ones I've gone over with you today. That this list is by no means comprehensive, and it's by no means thorough, by the way. You could take courses in this that last a whole semester, on these types of illnesses. We should not take it upon ourselves to diagnose or to advise people regarding their illnesses beyond the substance abuse services and beyond our referral duties. We should, however, become comfortable with working with people with co-occurring disorders, being comfortable in their presence, and sometimes that's a little harder than other times. I mean, I've worked with some people that it was a bit of a struggle for me to. I was on guard. My spidey sense was tingling that I might say something wrong or do something wrong or somehow set them off or what have you. And that's sometimes very hard for people to overcome, to become comfortable working with people. But it's something we need to do. You'll have plenty of opportunity to do it over the years as you pursue this noble profession. And hopefully you'll get real proficient at it. I think you will, probably. Whew, that was a lot, huh? I'm not going to expect you to be, expert marriage and family sex therapist, whatever, that people are bringing to your door. But I do, and your employers will expect you to be cognizant of some of the symptomologies and some of the particular challenges that are posed, for working with people who have co-occurring issues. And this is a place to start. So, I guess I'm done. And I'll see you for the next one.